Well, welcome to the GAP MASLD MASH Community Network. I'm really happy to be here with you today. Again, my name is Lindsey Pratt. I'm a PA. I have been practicing in hepatology for 15 years now. I'm at the University of Colorado Liver Transplant Program, and I see patients with a variety of liver diseases, many with MASLD and MASH on a daily basis. And this is an area of particular passion and interest to me, so I'm really happy to be educating on this topic. So today we're going to be comparing F3 and F4 fibrosis. And the way we're going to do this is use one patient scenario, so identical presentation, but with different non-invasive testing scores, and kind of compare and contrast what the management is going to be like for this patient. And just to put this in broader context, why are we talking about this today? I think of at-risk MASH being stage 2 or above. But stage 3 is really this transition point where I start to really worry about these patients, in terms of just the clinical implications, the risks of progression for them, the complications, how we're going to monitor them, really having to think critically about what treatments are appropriate at this point to prevent further progression to cirrhosis. And then the game really changes at F4 because then we don't have pharmacologic treatments that are FDA approved for them. And then we're really in this position of monitoring for decompensation and hepatocellular carcinoma and monitoring for indications for liver transplant. So that's really why it's just so important to accurately stage fibrosis in these patients and to distinguish between F3 and F4. And just to kind of review, histologically, what are we talking about with F3 and F4? So stage 3 on a liver biopsy, you're going to see this fibrous septa connecting or bridging the portal tract. So we call it bridging fibrosis, but by definition, no regenerative nodules. With F4, you see the fibrous septa between the portal tracts and architectural distortion, but the kind of distinguishing feature is the presence of those regenerative nodules and extensive fibrosis throughout the liver. All right, so you can use this QR code to register for the meeting. And I would also invite you to visit the GAP MASLD MASH Community Network. There's so much great information on there, educational videos and articles, just tons of educational opportunities. So please do check it out. Okay, so our patient is a gentleman named Sam. He's a 55-year-old Caucasian male, referred for mildly abnormal transaminase levels. And an ultrasound with increased liver echogenicity. So that means essentially noting hepatic steatosis, fatty infiltration on ultrasound. His main presenting complaint is fatigue, which of course we hear so commonly. It's very nonspecific. We do note that his body mass index is 33, putting him in the obesity range. So right off the bat, this is a patient that has obesity, abnormal liver enzymes, hepatic steatosis on ultrasound. You should already kind of have your radar up for MASLD or MASH in this patient. So diving in a little further to his past medical history, he has type 2 diabetes, hypertension, hyperlipidemia, and sleep apnea. So multiple cardiometabolic risk factors for MASLD and MASH. He denies any history of significant alcohol use. On physical exam, he has central adiposity, no hepatosplenomegaly, and no stigmata of advanced liver disease. So he's not jaundice, there's no clinically apparent ascites, no caput, no pulmonary erythema, no spider angiomata on skin exam. And then you can see his medications here. He's on appropriate treatment for his hypertension, diabetes, and hyperlipidemia. Okay, so just looking at his labs, or actually let's look at his vitals first. So his blood pressure is notably elevated here, consistent with his history of hypertension. Again, that BMI is 33, putting him in the obesity range. In terms of his labs, so his ALT and AST are in that range of elevation, 1 to 2 times the upper limit of normal, with the ALT being greater, which is what we commonly see with MASLD and MASH. Alkaline phosphatase is just at the upper limit of normal. Total bilirubin is still within normal range. The platelet count is 150,000, so still in normal range, but I would say at the lower end of normal. I'm just going to try, Jen, I don't know if there's a way, I've got you guys along the bottom here, and it's just, I just want to make sure that I'm not, it's blocking my view of the labs at the bottom. Oops. I don't know if there's a way to minimize. There we go. Okay. Hemoglobin A1C is elevated at 7.1, consistent with type 2 diabetes. Creatinine is still in normal range. INR is in normal range, so his synthetic function is still normal. We don't have an albumin here, but I'm going to assume for our purposes that it's normal. His ferritin is significantly elevated at 780. So are we concerned about this? You know, are we concerned this patient might have hereditary hemochromatosis? We see these elevated ferritins quite commonly, actually. Ferritin is an acute phase reactant, so it can be elevated in the setting of inflammation, which we of course see with MASH, with alcohol use. With that iron saturation being 30%, that's really not consistent with presentation of hereditary hemochromatosis. However, you can still check an HFE genetic test to rule out hereditary hemochromatosis in this patient, because, you know, if they were a homozygote for the C282Y mutation, that would certainly change your management. And then, you know, even if the patient were a heterozygote, in those cases, we don't see clinically significant iron overload. We know that sometimes those patients, if they have a second hit on the liver, such as another liver disease like MASH, that could accelerate progression. So you could consider definitely getting an HFE gene test on this patient. Also notable is that his ANA is positive. I would not be overly concerned about this. This is again not uncommon, and it's not specific for autoimmune liver disease. And we also have below here a negative anti-smooth muscle antibody, which is more specific for autoimmune liver disease. And then you can see that his testing for viral hepatitis is all negative. So we're going to move on to non-invasive fibrosis assessment. First of all, using a FIB-4, and a FIB-4 is a readily accessible test. You can calculate this in an app on your phone like MedCalc, depending on what medical record system you have. Like we use Epic, and the FIB-4 is embedded. You just type in .fib4, and it's a smart phrase, and it'll just calculate it for you. But all you need is the patient's age, their platelet count, and their ALT and AST. So you need a CBC and a CMP, which we're getting on most patients. If their FIB-4 calculates out at less than 1.3, then you can reliably exclude advanced fibrosis, and you can rescreen this patient again in 1 to 3 years, depending on how worried you are about them, what their other risk factors are to have more advanced disease. If they fall into the intermediate category of 1.3 to 2.67, then this patient really does warrant further testing to assess for significant fibrosis. You can see that our patient, his FIB-4 calculated out at 2.74, which definitely puts him well into that intermediate risk zone for significant fibrosis. So this is a patient that I definitely would do a secondary test on. Really, the hope is that the FIB-4 is getting calculated in the primary care setting. So we move on and we get a FibroScan in our patient. And we're going to assume for our purposes here that this is a good quality FibroScan. I mean, his BMI is under 35. We start to worry above a BMI of 35, FibroScan can be a little bit less accurate. His ALT was greater than 80. So you might worry a little bit that the FibroScan could potentially overstage this patient due to that inflammation. But let's assume for our purposes that we got a good study, that the IQR median is less than 30% here, that the operator was successful in getting these images. And his FibroScan result is 11 kilopascals, which again, so FibroScan works by correlating the liver stiffness measurement to fibrosis. An 11 kPa would put him in the range of F3 or stage 3. And then his CAP score, which CAP stands for controlled attenuation parameter, it's a measure of hepatic steatosis in the liver on FibroScan, does confirm significant steatosis in the liver, which would support your diagnosis of MASLD in this patient. We happen to get an ELF test on this patient. I'll be honest, I don't order a lot of ELF tests in my clinical practice, mainly because I'm worried about insurance coverage with the test and I don't want the patient to get a big bill. But the ELF test is a proprietary serum-based test that measures 3 biomarkers of fibrosis. And it can be a really nice test, even like if you need a kind of a tiebreaker or you want to support your FibroScan result. And in this case, the ELF comes back again with the patient looking like they're in kind of that F3, stage 3 range. And so when we look here, and we've got 3 non-invasive tests now that are relatively concordant, which is nice to see. Okay, so is there any further testing you would like to perform on this patient? I'll give it a second just in case anyone wants to type in here. Do you think this patient needs a liver biopsy or an MR elastography? So I personally don't think so. I think that we have 3 NITs that are concordant that all suggest F3. And I also think that this patient's liver labs are in range for what I would expect for MASH. And when I look at platelet count, synthetic function, it's in range for what I would expect for F3. So I think that when I look at the whole clinical picture, the labs, the imaging, the NITs, I think they all agree in this case. Also, there's nothing in the initial serologic workup that has me concerned that we're missing a competing etiology. You know, if this patient had had a positive smooth muscle antibody and I was worried about autoimmune hepatitis, or if there was a strong family history of autoimmune disease, then I might consider a liver biopsy. Or if the liver enzymes were out of range for what I would expect for MASH alone, like let's say his ALT and AST had been more in the 250, 300 range, which would be pretty elevated, where I may not trust the FibroScan as much, for example, I might want a liver biopsy to make sure that I am not missing another etiology for this patient's liver disease. But I feel pretty confident here that this patient is an F3. How would I stage this patient? I would say this is confidently an F3, and I would kind of go from there. Now, I will say that I have patients that would like a liver biopsy, and I definitely give that to patients as an option. Liver biopsy is still considered the gold standard for staging fibrosis and definitively identifying what the etiology of the liver disease is. And if patients would like to pursue a liver biopsy to have just confirmatory test of all of the above, I'm not opposed to that. And this patient has, a normal INR, normal platelet count, so risk of a liver biopsy in his case is very low. So you could offer that, but I don't think it's necessary. I also don't think an MRE is necessary to confirm our findings thus far. Okay, so let's talk about how we would treat this patient and how we would monitor him. So first of all, this patient would be a candidate for Resmetirom. So Resmetirom, or the brand name is Rezdiffra, is a liver-targeted thyroid hormone beta agonist that has been shown in clinical trials to be very effective in improving steatohepatitis and improving fibrosis. It is FDA indicated for patients with MASH with F2 to F3, stage 2 to stage 3. You do not need a liver biopsy for a patient to qualify. It can be based on NITs. It's a very well-tolerated drug. The most common side effects are nausea and diarrhea. I've been using it for over a year now in clinical practice. I have found it to be very well-tolerated. We are starting to see our first round of patients now getting repeat liver stiffness measurements, usually FibroScan at 1 year into treatment. And what we are seeing clinically is that patients normalize their liver function tests and that their fibrosis does go down at 1 year, which is really exciting to see. In terms of lifestyle modifications, so you would definitely want to counsel this patient. It sounds like he already doesn't drink alcohol, but definitely counsel him no alcohol. I generally tell patients with stage 2 or above fibrosis to not drink alcohol. We know that alcohol can accelerate disease progression. Most patients know that alcohol is like a toxin to the liver. A lot of them are not aware that alcohol can also add fat to the liver. So you definitely want to counsel about alcohol use. I discussed with the patient that still the foundation of treatment is nutrition and exercise, and really a goal of a 7 to 10% of total body weight loss to really improve steatohepatitis. And what I recommend specifically is a higher protein, lower carbohydrate, low sugar, kind of Mediterranean diet, really focusing on avoiding ultra processed foods, encouraging patients to sort of shop the perimeter of the grocery store, definitely getting adequate protein so that as they lose weight, they are not losing too much muscle mass. And then I counsel them on exercise, and, you know, a goal of at least 30 minutes of movement per day. If they're not exercising at all, then just, you know, starting with just walking and going from there. If they're already exercising, the goal would be some combination of cardiovascular exercises as well as resistance training to maintain their muscle mass, which can help support their weight loss maintenance over time. You could also consider a GLP-1 receptor agonist like semaglutide or tirzepatide. These medications are not yet FDA approved for MASH, although we expect that semaglutide will get that FDA approval this year, but they are approved for obesity and diabetes. And so a GLP-1 would also address those diagnoses that our patient has here, but also likely help his MASH. So that's definitely something to consider. In terms of monitoring for HCC, so we know patients with MASH without cirrhosis are at higher risk for hepatocellular carcinoma. So my F3 patients, I do start screening for HCC, typically with an ultrasound plus or minus an alpha-fetoprotein every 6 months. The one caveat I will add here is be mindful of limitations of ultrasound with body habitus, because for some of our patients, especially if BMI is greater than 35 or 40, ultrasound's just not going to be that sensitive at picking up very small lesions. And if you do get an ultrasound back that notes poor visualization of the liver, you might want to consider doing cross-sectional imaging like an MRI or a triple phase CT scan. Okay, so now we're going to take the same patient, still our 55-year-old male with obesity, with multiple cardiometabolic risk factors, as you can see, without significant alcohol use, same physical exam, obese abdomen, but no stigmata of advanced liver disease. His labs are significantly different, though. Just going to minimize the screen here. Oop. Hang on a second, Jen. There we go. Okay, I lost my slides for a second. Okay, so when we look at his labs, ALT and AST are the same. So transaminase is still elevated in that 1 to 2 times the upper limit of normal range. But when we look at his total bilirubin, it is mildly elevated in this case. Now, this could be Gilbert syndrome, and you could certainly fractionate the bilirubin to see if this is just primarily indirect hyperbilirubinemia, but it should trigger your concern that, you know, is this a sign of decreasing liver function? Platelet count he does have thrombocytopenia with a platelet count of 128,000. So this should really raise your suspicion here of more advanced fibrosis, possibly cirrhosis, developing portal hypertension when we see a low platelet count. Again, hemoglobin A1C is elevated, consistent with type 2 diabetes. Also of note here, creatinine is it's significantly elevated here at 1.3, and we definitely can start to see some chronic kidney disease with more advanced liver disease. So something I would definitely be paying attention to. Again, that elevated ferritin, most likely it is just elevated in the setting of inflammation from MASH. It's an acute phase reactant, but you could follow up testing with an HFE gene test just to exclude hereditary hemochromatosis, but less likely with that iron saturation of 30%. Again, the ANA non-specific for autoimmune liver disease, so I'm not concerned about that, especially with having that negative smooth muscle antibody. And again, viral hepatitis testing is negative. All right, so we're still going to do I see a question here from Lauren. So thoughts on secondary iron overload, secondary to MASLD? Yeah, we can definitely see that as well, for sure. Good point. Okay, so in this patient's case, so we do a FIB4, again, using the platelet count, AST, ALT. And this time his FIB4 comes back at 3.36, so well within that high risk range for advanced fibrosis. So this patient definitely needs some secondary testing. We do a FibroScan. And again, we're going to assume here this is a good quality study. And FibroScan comes back with a 21 kPa measurement, which, if you consider the Baveno criteria, which uses liver stiffness measurement by FibroScan and platelet count, this patient is in then the cirrhotic range with concern for clinically significant portal hypertension with a platelet count less than 150,000 and with a kPa of 21. The CAP score, interestingly, is lower than in the previous case. So we still see steatosis here with a CAP score of 245, but we see less. And this is kind of what we see sometimes with what we call burnt out MASH, where as you start to see higher levels of fibrosis, you actually see less of the steatosis. We do, again, get an ELF test on this patient, and the ELF test comes back in the cirrhotic range at 11.4. And notable here, too, is that we know with the ELF test that specificity gets higher for advanced fibrosis and cirrhosis at those higher ELF scores. So again, I look at this, we have 3 non-invasive tests here that are concordant that all suggest that this patient is in the cirrhotic range, F4 range, with concern for developing portal hypertension. Right, so again, is there any further testing you'd like to perform on this patient? I'll just give it a second to see if anyone wants to pipe up here. So I think, again, the question comes up, do we need an MRE to confirm? Do we need a liver biopsy to confirm? I would say no. I think, again, we have concordant NITs on this patient that all support this diagnosis of F4. When we look at blood work and we look at 3 NITs, it supports the diagnosis of F4. Again, I don't have concern for competing etiology in this patient. If I did, I would certainly consider a liver biopsy, or again, per patient preference. If this patient wanted to have a confirmatory liver biopsy, you could offer that. In this case, since you have concern about portal hypertension, you actually could consider doing a transjugular liver biopsy if you were to do that. Again, how would you stage this patient? I think this patient is an F4, and I feel confident about that based on the NITs that I have and their clinical presentation. So let's talk about how we would treat this patient and how we would monitor him. So unlike our previous case, because he has F4 fibrosis, he is not a candidate for Resmetirom, unfortunately, and there are no FDA-approved pharmacologic therapies for MASH with cirrhosis at this time, although there's a lot, of course, in clinical trials and being studied. In terms of diet and lifestyle, again, I would reiterate the importance of complete alcohol abstinence, just because we know that alcohol could accelerate progression and increase risk of decompensation in this patient. As far as diet, I would still really encourage that higher protein, low carb, low sugar Mediterranean diet. Really, with a patient with cirrhosis, discussing that risk of sarcopenia and encouraging adequate protein intake. Again, encouraging exercise, ideally some combination of cardiovascular exercise and strength training. In a patient with F4, you certainly want to monitor for hepatocellular carcinoma, at minimum ultrasound every 6 months. Again, paying attention to the impact of body habitus on the sensitivity of ultrasound. Consider whether or not you want to be getting cross-sectional imaging with triple phase CT or MRI. And then again, because this patient has cirrhosis, and by FibroScan with that 21 kPa indicating that they are in that range of concern for clinically significant portal hypertension with thrombocytopenia, I would do a screening endoscopy on this patient, and then, depending on findings, consider starting a non-selective beta blocker for variceal prophylaxis in this patient. You could consider a GLP-1 agonist for this patient. With patients with cirrhosis, I think we need to, if we're going to use the GLP-1s, we need to really pay attention to the potential to develop significant sarcopenia, because I have had patients where we had to stop their GLP-1s because they just had significant weight loss and muscle mass loss that was very concerning. So if you're going to use a GLP-1 in this population, definitely attention to that risk of sarcopenia. Okay, so again, just comparing this identical patient presentation, but with different NITs. So again, Fib4 kind of in that indeterminate range in the first case versus in that real high risk range in the second patient. With both, we went on to do secondary testing with a FibroScan. In one case, it suggested F3, and the second case, it suggested F4. And the ELF score correlated nicely in both cases. And I think this is an example of where an ELF score might be really helpful just to support your findings with your FibroScan. And again, I don't use the ELF score a lot just because we're worried about insurance coverage with it, but this is a good example of where it could be used to really support your findings. So how do these two patients compare in management? I mean, again, with a patient that is F3, you have that option of pharmacologic therapy with Resmetirom. Once they reach F4, then you're kind of more in this position of more monitoring and risk stratification. Definitely both patients need screening for HCC with imaging every 6 months. The patient that's in the F4 range, you're going to want to be monitoring them for potential decompensation, screening for esophageal varices, screening for hepatic encephalopathy, checking for ascites and edema, checking to make sure they don't have indications for liver transplant evaluation. In terms of distinguishing between F3 and F4, typically in my practice, we are using FibroScan, I would say, first line. Like I said, I don't tend to use the ELF score as much. In terms of if my NITs were not concordant, like they were in these cases, if I had indeterminate NITs, or if just the patient's clinical presentation, their labs, their imaging did not agree with their NITs, then I would strongly consider getting MR elastography or just doing a liver biopsy to make sure that I had accurate staging. And I think the importance of the accurate staging is highlighted here in the sense that you wouldn't want to overstage a patient with F3 and then miss the opportunity to provide pharmacologic therapy and be able to potentially halt that progression of fibrosis. But alternatively, you certainly don't want to miss cirrhosis given the high risks for progression and decompensation in that patient population. But I think that at the end of the day, you have to really interpret these NITs in clinical context. Don't forget the patient in front of you, kind of how their history, their presentation, their physical exam, the labs you have, the imaging that you have, and then interpreting those NITs in that context to kind of get an accurate picture. Again, HCC surveillance is important beginning at stage 3. These patients need imaging every 6 months. I also do ask about family history of cirrhosis, family history of HCC. That would potentially escalate me to be doing at least cross-sectional imaging once a year in this patient population, especially if their body habitus is going to make the ultrasound less sensitive. Okay, so that is the end of my slides.